All right, welcome back. I hope you're having an amazing time so far. Next up, we have a panel titled The State of AI in Hospitals. Please join me in welcoming our panelists to the virtual stage. And I'll hand it over to Hamilton, our moderator.
Well, thank you. We'll start with some introductions. I'm Hamilton Baker. I am a pediatric and congenital cardiologist from the Medical University of South Carolina in Charleston. I'm also director of the AI Hub there and lead the research alliance between MUSC and Clemson University. I'll have the other panelists introduce themselves, starting with Sanji Fernando.
Hi, my name is Sanji Fernando. I'm responsible for AI products and platforms here at Optum. We design and train capabilities and software that allow us to deliver a myriad of services across Optum, enabled with machine learning and artificial intelligence. And I'm also responsible for the overall platform that we use across enterprise to design, train, build, and deploy models, both retraining over time and addressing key aspects of fairness and health equity when we design and train these models.
Excellent. Let's move on over to Jeffrey.
Thanks, Hamilton. I'm Jeffrey Eyestone. I'm Healthcare AI Advisor at CognitiveScale. We're an AI software platform provider working with a lot of healthcare organizations, large payors like Anthem, United Healthcare, provider organizations like Kaiser Permanente and Ascension. Our Cortex AI software platform enables the development, operationalization, and scale of trusted AI applications in areas like care optimization, claim processing and revenue cycle, service experience, and a number of other areas. And more recently, I mentioned trusted AI solutions. We do a lot in that area as well, pertinent to healthcare, helping to build trust and explainability in the AI applications that we are developing, as well as our clients and their third parties. Great to be here.
Excellent. Thank you, Jeffrey. And Hanqing.
Hi, my name is Hanqing Cao. I have been playing with data in healthcare data for in healthcare industry for over 20 years now, and currently I'm the program director of data science at New York Presbyterian Hospitals. So some of my responsibilities including building the AI capabilities and overseeing data science projects, basically trying to running from the beginning to the end of the projects and across the enterprise. So I think that the models is aimed to improve the hospital's efficiencies and the clinical outcomes in the meantime. And so yes, glad to be here today.
Well, fantastic. That is a great panel we have put together here. I'm proud to be a part of it. And with that, I think we'll dive right into the first question coming up on the screen here. All right. The first one is, it's been a tough 12 months. Has AI played a supporting role during COVID? There's an awful lot to say there. But I think I will start out by directing this question to Hanqing. What are your thoughts on this one?
Yeah, actually, definitely AI is playing a supporting role in the COVID situation. I think that if AI has multiple components, let's say they have machine learning and have robotic process automation, then the robotic automation, process automation, basically RPA, definitely plays a role in the day-to-day activities. For example, we use the RPA to track the ventilators. That's how many are in use, how many is available automatically, right? Rather than a human being doing that. We also track, let's say, PPEs, like this equipment for protecting this, like the masks, those kind of things for the physicians, and also trying to check the usage, if we need to put more like supply chain, like those kind of things, definitely yes. And a third example is that we have developed this called NYP COVID Pass, which we would track the, basically let the patients as well as staff to self-report any symptoms, either negative or positive symptoms of COVID, and then we can see that, how to direct the resources, how to make sure that we, can take care of people, including staff, appropriately. Yeah, definitely. However, on the other hand, for machine learning, I think because it happens so quickly and everything is dynamic, right? About treatment, trajectory, patient profile. So I think although there are like tons of publication, right? Maybe 100 papers a day. However, I think that the usage, the implementation of those models to real applications still would take some time to be, realized. That's my observation.
Yeah, if I can mention too, like, I think that's a really great point. All the things that Sanji described are absolutely essential to improve the efficiency in hospital operations. But if I go back to like last March, or maybe around this time last year, there was this like real interest in trying to apply machine learning to quote unquote solve the COVID problem and solve the pandemic. And a lot of us who are in the space, I think maybe struggled. I know I personally struggled because we didn't have like anything to learn from, essentially. There wasn't like good evidence, or there wasn't large sample size, there weren't great training examples because this was all brand new. And in reflecting on that time, some of the things that were sort of tried and true, and don't get me wrong, I'm the biggest fan of machine learning, but things like our epidemiological models, our time series models, those are the things that proved to be the most probably accurate, maybe is the right way to describe it, in telling us where this was headed. And so it was interesting because it was a time where I think as a country we were struggling, and as folks involved in machine learning, we wanted to help, but it was hard to really say that we were really making an impact, especially in those first few months. I think now with more data, more examples, more patterns to explore, I'm sure we will have a bigger contribution. But in those first few months, it was a bit frustrating.
Yeah, that's a fantastic point. I think that in the initial stages, AI for logistics from a public health perspective, tracking, especially countries where they had systems already in place, was probably the quick wins. But I couldn't agree more with all the comments that have been made. And in our own institution, we had a lot of one-off research projects that were really fantastic. We had a NLP model that was looking at the telehealth interactions. So folks would have a quick appointment via telehealth where they'd actually type in or speak in information. And so it quickly built up a reasonable database to look at. And we were able to very early on identify the loss of smell and taste almost before that had become so obvious to everybody. But as Sanji was saying, we couldn't really clinically implement it quick enough. We couldn't really get any clinical ROI out of it. So it was a bit frustrating at first, and now things are starting to come to fruition more. So Jeffrey, do you have any thoughts on the question?
No, these are great points. I'd add, agree, a year ago, there were all sorts of public health challenges, and the year we've had has been incredible. Total agreement that AI's played at least a supporting role, if not pretty important role in a lot of different environments. Our perspective on it, you have kind of the obvious use cases that the general public sees: predicting cases, hospitalizations, the curves, right? Even things like ICU capacity. All of those great impacts had practical impact on things like staffing and supply chain, and who needed extra capacity, where were we going to put temporary facilities, that sort of thing. And that was leveraging a lot of external data, external models, and then or healthcare organizations, large healthcare systems, or even health plans now we're looking to marry that with those individual insights, predicting at-risk members. And we were all learning, obviously, how to do that and how to improve those scores. So marrying that kind of public health level and community risk score information with individual patient risks, and then being able to even impact the journey, the care coordination and those sorts of things. So all sorts of AI use cases. I use this term orchestration. That's a bunch of data, models, insights, inferences, you name it. Orchestrating all of that into a meaningful way. It's just been an amazing year. You see telehealth and virtual care coming on, and all sorts of resources that are leveraging AI now. The impact on digital transformation and public health has been great. So we've just seen a lot of progress, but yeah, it was tough at the beginning for sure.
Yeah, I think it's not necessarily AI, but the impact on telehealth was obviously gigantic. But I think in some ways, even as we start to begin the process of at least calming down COVID, not necessarily conquering it, but I think it has opened up a wealth of opportunities if we can find a way to bring in that information that's contained in that clinical interaction in a better organized way than our usual EHR process. And we're working on that, but we haven't really been able to nail that down. I don't know if any of you have had experience with that, or Hanshin at your institution, if you were looking at something similar to that.
Yeah, actually, I was going to say that one change, which is a good change from data science perspective, is that I think countries or hospitals have never been so collaborative before. Sharing data, sharing insights, sharing, because we are having sharing a common pain, right? Something new to everyone. So everybody, so it opens the door, or technologically also there's a need to share data across, institutions, even countries, collaborate. And I think that by nature would, facilitate at least the development of AI in medicine.
Yeah, that's a great point.
Go
ahead.
Sorry. Yeah, we've seen similar use of the data, especially external data and insights. Our solution, a core element of it, is what we call profile of one. So being able to pull all that, external and internal data and insights together, declared data, observed inferences, into a profile across numerous personas. So it might initially be a patient, but also, again, that external public health data on community risk scores and that sort of thing. Being able to combine all that and then derive all these insights or apply the, say, risk score models. It's not just the score and identification, it's how do you then change the trajectory. So that profile of one is a key foundational element of a longitudinal ability, obviously temporal, multi-dimensional ability to pull all that data that it takes to then derive the insights that actually, improve care or drive a result. So we're very familiar with that data part of the story here. That's kind of the prerequisite to any insights, especially in these COVID use cases where there's been such a reliance on multiple data sets and insight engines, models, et cetera.
Yeah, I think data is an incredibly important part of the puzzle. But if you imagine if we were, knock on wood, to ever have to go through an emerging health crisis like this current one we're in, and this goes maybe back to you, Hamilton, if we look for what's driving it in an unsupervised way, are we ready to translate that to clinical care and treatment? Historically, we've held up, key concepts like the research clinical trial and true, differentiated testing in that way to understand what the implication is. If we see an insight, like you mentioned, the loss of smell and things like that. And I think that's something we have a lot of work ahead of us to do, to decide how much causal relationships we could tease out of an unsupervised analysis, how much you as clinicians are comfortable testing some of these hypotheses, and do the ground rules change during an emerging crisis? I'm not sure, but there's a lot for us to uncover here. the data is an incredibly important part of it, but I think it also then leads to the question like, what would we do differently, or how would we do things differently? How would we collect or be confident with the evidence that we see that's not just simply correlations? And how far do we want to test what could be, have very deleterious impacts to the care of a patient when we think about unsupervised learning in this emerging crisis situation.
Yeah, that's a great point. To what you're saying, I think the slogan "move fast and break things" doesn't work so well in medicine, right? Because we can't break things. We can, but I have to say, I was just amazed at the speed at which funding came out to support projects for COVID on a research level. And I think, a very traditionally slow process was sped up very quickly. So, to your point, I think as we face those challenges, and to Hanqin's point, having that enemy to all face together really allows us to change some of the way that we do things, and hopefully speed up some processes that need to be sped up, but not to rush things that just simply can't be rushed. Well, I think we nailed that question, unless anybody else has any further comments on it. All right, I'll take that as a no. I think we're ready to tackle the next one. All right, what advantages can AI provide a hospital as we seek to improve healthcare? And it looks like we have to give examples. We can't just wax on about all the wonderful things that we're going to do. Well, I think I'll give this question to Jeffrey.
Okay, sure. Yeah, I'm looking forward to what you folks in actual hospitals say to this question, but I can certainly point to where we're working in this area. I mean, we've touched on, things like revenue cycles, so financial applications, and certainly there are administrative applications as well. But, I think, care management or care optimization use cases that impact, the quality of care and the patient journey through a healthcare experience. And those interactions could be, patient-facing interventions or provider-facing interventions. There are obviously many of those, everything from diagnosis and treatment. We hear a lot about pathology and radiology AI solutions, but we're working in areas like determining at-risk patients and then how to improve their journey. That could be hospital readmission or risk of an event or condition and those sorts of things. It can also be, where algorithms or models are doing things like helping with who gets discharged and some of those sort of considerations. And the part that I'll add to this, though, where we're really focused is building in that trust layer that I mentioned in the introduction. So, really digging into how can I be sure, say as a clinician or a case manager, that this AI-powered application can be trusted, that it's accurate, bias, fairness, explainability are all transparent and understood, acceptable rates, that sort of thing. Still early days, don't get me wrong, but that's an important part of, where is AI working in hospital situations, especially those clinical ones, as you said, Hamilton. We can't, fail fast, fail often in healthcare, like the saying says. So these solutions have to be tested and trusted. So, that's just an area of concentration for us that is very pertinent these days, from, clinician skepticism to, compliance and risk management. Where's the data coming from? How is it being used? And can I trust that this model is, again, accurate and all of the bias, fairness, and explainability areas. So lots of use cases. We could talk all day about those administrative, clinical, and financial ones. And the last thing I'll say, again, it's not just, the risk score itself or the model output, it's how is that being used? How actionable is it? So even at that trust score level, can I trust the model? There are, there are outputs of that can help drive, like maybe these are the cases that a human should review, human in the loop, not leave it to ML, for example. So all sorts of use cases around AI where you want to be sure to focus on how actionable are the insights. That's kind of what we're focused on. But again, I'm curious what the folks in the clinical settings are doing. So I'll turn it back to you, Hamilton.
Well, I would imagine, Han-Xin, you have a good bit to say about this. You want to make some comments?
Sure. I think that Jeffrey has almost included everything about AI in medicine, like interpretability, transparency, trust, fast, fair, bias, like everything, right? And I'm just like starting from the application, like very specific application perspective. I think that from my perspective, I think there are two advantages of AI. I'm just answering the question, right? One is that AI sometimes can direct the right resource to the right patient at the right time. This is actually part of the CDS, right? Clinical decision support. I think I can give them basically, for example, in the patient monitoring, the ICU, right? So you have lots of data, but the physician or nurses cannot possibly to look at every single data point, right? So if you have an AI to have a very special eye to watch the particular event, either it's like hemodynamic instability, sepsis, or hypoglycemia, or anything, right? Like the deterioration, then it will be very helpful to say, hey, this patient right now needs care. This is one example, right? Another advantage I can see is that AI potentially has the capability to be more accurate in diagnosis than human beings, especially as Jeff said in radiology pathology, because AI is able to see millions of images and then come to some kind of a predictive algorithms that will summarize from all these millions of data points versus any single radiologist could not possibly review, right? And so this would potentially give AI a unique advantage over human beings because just the sheer amount of data it has been seen. So I think these are, and then of course their revenue cycle, we're also doing revenue cycle project. I try to operationalize of these, some of the, administrative operational and try to, let's say, for our hospital perspective, how to, let's say, denial management, how to, conquer, or how to, we can get paid as we were supposed to get paid, like from the, from the payer, right? So those, of course, AI can help as well, yeah. But I think mainly from the patient improved care perspective, these are two things, which is direct the right resources. Another is the more accurate, is the, the key advantage I can see.
Yeah, those are great examples. And, I think to that, I would add the fact that I think we all are really excited about AI accomplishing these high level tasks, narrow tasks at that, but being able to do it better than humans. I tend to shy away better than doctors or humans because it's not a very popular term. There's no question that in narrow tasks, it already can outperform a human being. But I always try and stress the synergy so that we don't scare the radiologists. But, more importantly, I think that while all of these, very sexy ideas where AI is going to accomplish these monumental goals, I think in the early stages, we're going to need to concentrate and be satisfied with the boring versus the sexy, tackle those data-rich, repetitive, low-risk tasks that we as physicians would really like to have done for us. I also think that a huge advantage that AI could provide for hospitals is patient relation management. It's a time sink. It's a lot of energy, but it's so crucial in the success of a healthcare enterprise. And with the incredible progress that has been made in natural language processing, understanding and generation with, GPT-3, et cetera, that's where I think, it could make monumental differences in not only just a healthcare institution interacting with a patient, but really improving that patient's care through gentle, healthy, well-received nudges, that sort of thing. I don't know if anybody else has any more comments on this question. It's a good one.
I could share, I think in the category of boring to some extent, back in 2016, when we saw this explosion of artificial intelligence, especially driven by deep learning and deep learning neural networks, there was a lot of interest in clinical decision support and automation, categorizing clinical images in pathology and radiology, dermatology. The Stanford diabetic retinopathy paper was quite important. But as we looked at our business and looked at what we do and where there could be clear application, one thing that emerged was revenue cycle. So I was still in a research organization at that time, but our first product that we launched that became now one of our fastest growing products at Optum is called Optum Case Advisor. So in the revenue cycle process, oftentimes a third-party physician is required to review the case and provide an independent perspective on the level of reimbursement. So you've been admitted, but there's a question, is it an inpatient admission or should it be an observation? And that could have a significant impact to the reimbursement, not really your care. And so we asked physicians on the floors in an ICU, in an inpatient care setting, to try to decide what to route to this third-party reviewer. And it was a burden on them. They weren't sure which to send to, which cases should be deemed appropriate. And so what we did was we trained a neural network on the reviewers and what cases they felt supported inpatient admission. And so now with Optum Case Advisor, a hospital system can send us all the cases, and we will evaluate them with our model without any cost and recommend which ones should have a human in the loop review them. This saves time and expense and effort on the physician side. It saves or it optimizes and maximizes the time and effort for third-party physicians in our case advisor business and Optum Physician Advisory Services. But I think it's that classic example where it's a necessary component of our healthcare system, a necessary component for the reimbursement. It requires a really skilled human to review the cases that are important. But there's a lot that they probably don't need to ever open up the file for or the chart for. And so we were excited. I think we launched that in 2018. It was the first revenue cycle product to use a deep learning neural network. And we've continued to retrain it and grow it. But I think that's a good example where, especially on the administrative side of healthcare, we can hopefully use the burden for hospitals and providers and maybe focus people more on the more complex decisions and maybe even the more complex care.
Yeah, I would like to echo that. I think that like some cases are in the borderline so that even two advice or reviewers may not agree with each other of the like clear observation or inpatient, right? So
yeah. And so you could tune it to your score. You could decide which ones should be reviewed. You want to review more or less. But there are probably lots of cases that will not likely support an inpatient admission level of care. And we should try to take that off of everyone's plates. More importantly, just that step of asking a physician in the care delivery process to make that decision on any case, if we could take that off their responsibilities, that's probably a time saving. And we've heard that from folks that it's just one less thing you have to do.
Yeah, that's a great example of a task that most physicians aren't very interested in doing, and certainly any minute or even seconds that can be saved in our days, we're very appreciative of. Well, I think we knocked down another one. It was a great conversation around that question. So let's move on to the next one. Next question is, what challenges do hospitals face in implementing AI solutions? Again, examples, please. I like this one. I think now that we've gotten a bit over the hype of AI, it's time to really dig into those challenges. And I think you're kind of up in the queue here, Sanji, if you'd like to start out on this particular question.
Yeah, it's come up before. I think I was at HIMSS and we were talking about this with one of my colleagues, Tushar Malhotra. One of the biggest challenges is what is your aspiration as a health system? How do you want to employ, develop, build, and train machine learning models? And what is your appetite for investment? Because you're going to need a certain level of talent to do that well. Being able to leverage trained models and trained solutions and implement them in an operational setting may require less teams, less skilled and talented individuals that have specific skills around machine learning, data pipelines, model evaluation. Maybe does require a lot of investment. And so the question is, do you want to build and train novel models for your health system and all the burden of investment that comes along with that? Or do you want to take advantage of trained solutions that might come from third-party providers, from the open source community, things like that? Every day it becomes easier to use and deploy machine learning. Cloud providers like Google and Facebook and Amazon and Azure have lots of great tools. And so, like if you have to understand concepts in a block of natural language, those tools are readily available to you. They're trained and pre-trained by companies that like those I mentioned and many others. And so you've got to ask yourself, what is your aspiration level? Because I feel like there's a certain amount you could do with a set of folks who can enable and use those tools. And then if you want to build your own novel models, that might be a step of investment that you have to consider, not only the work required to hire and equip those folks with the tools they need to do their work, but also make sure that you have enough data to train and address things like fairness and equity in a appropriate way. So it is an interesting bar. I think that's one of the biggest challenges for maybe small to medium-sized health systems and what they want to do versus like larger university-based systems that might be attached to an academic program and things like that that have a lot more resources to tap into.
Yeah, that's a great comment. I think it's a question or questions that are facing really the majority of healthcare centers, because most aren't those large university ones, although those are the ones we hear the most about when it comes to AI. I think that question of in the future, what's your overall investment and ongoing investment going to be in building a team and deciding when to build or to buy, right? Are you going to try and create, as you mentioned, your own models, or are you going to work with a vendor? And I think the point you made that that large versus small healthcare institution, it's really a spectrum, right? There's all along that pathway, and so some sort of a mix of those two, building or buying, is what it's going to be. But it's so difficult to figure out what your institution is prepared for and which way to go. I wondered if anybody else had comments on this question. Let's keep it going.
Well,
go ahead.
Sorry. Oh, I was going to add, I think just I'll that spectrum is so important too. I think making some decisions about where your data is, maybe what public cloud you're going to use, are all going to play into that, because you're not in a single bucket of small, medium, large. You're probably on this range. But we hear about all these models where folks train models on sepsis risk. There's a bunch of papers about them. A bunch of large academics have done work there. Medium-sized companies, it's you got to ask yourself, how much data do I have? Where is it? How much am I going to train it? What tools am I going to use to train it? And I could fall in different spots on there and decide what my aspiration is. But you probably need to pick out where your data is going to live, and not to be too prescriptive, but you're probably going to do this public cloud to tap into the utility of the compute cycles you might need, especially if you want to train your own models.
Yeah, I was just going to add, you guys are making some great points here. Just building on that a little bit, some of the more advanced use cases like, care interventions based on personalized insights. Hamilton, you said nicely in the last question, some of these use cases are so reliant on data from disparate systems and across distributed networks even, that another important consideration in implementation is just speed to value, not just how fast can I turn it on, but can I realize value? And I'm talking really, standalone applications, not necessarily third-party embedded. Some of those a bit easier to consume, but it's not just that technical lift of implementation, but again, how do I orchestrate and operationalize the whole solution? So, some of those personalized insight-based solutions, if we're talking, let's add EMR data and eventually external data, IoT and home health and devices, all of that sort of stuff, which will be great when we can do that and deliver that level of personalized interventions. But in the meantime, things like customer service and revenue cycle, where it's a more contained environment of systems and workflows, and especially access to data, sounds fairly obvious, but the speed to value there is still much better, and the value is great. We're playing for, real upside in terms of, efficiencies, savings, collection rates, and that kind of thing. So, the kinds of things Han Qing's working on the rev cycle side are some of our longest standing solutions as well, as far as what's been in production and delivering value. And even customer service, you mentioned, managing a patient journey on the administrative side. There's still a lot to do there, but plenty of value being driven in some of those less sexy areas, as you mentioned.
Yeah, one point I'd like to add on top of all these great points is, if we get back to the question, what challenges do you face implementing AI solutions in a hospital setting? People, clinicians, getting clinician buy-in is, it's not always easy. And I think being a clinician primarily and now getting involved in how we're going to implement a lot of this, I think having more clinicians involved in the implementation as champions and even higher up is very important. But I think that is going to be quite a challenge. I think you find a large variation in opinions on AI in medicine and machine learning in medicine from clinician to clinician. When it comes down to it, though, for most busy clinicians, it's about time, right? They don't care if the solution contains the most extraordinarily sophisticated deep learning model, or if it is as simple as a calculator. If it saves them time and it's easy to use and does something productive, then it's fantastic, right? And so I think especially in those early stages of implementing either particular things or wide scale things, having a well thought out plan to get the clinicians involved and have them help you get over the hump, because there's always going to be humps. And I've seen it happen. Sanjay and others were referring to the sepsis models that were frequently created. Trying to implement one of those without thinking about the user to a very large extent will likely wind up potentially shelving a pretty reasonable model. So that's my 2 cents, is you got to have the clinicians on your side, at least most of them, and especially a good bit of them in that early stage.
Yeah, I cannot agree more. I think that I was going to say that how to get buy-in from the end users, clinicians, nurses, right, physicians. If, for example, our model is great, but for example, it requires physician to give us data, let's say do more charting, then it's like, bittersweet, right? It's like more difficult. And also, and another thing was about the end user is that in our one of the cases, for example, we let's automate stuff, right, using AI. And then people lost their job potentially. So there could be resistance from that aspect of you can see that they probably understandably, they want to, protect their jobs. It's another, end user kind of, challenges we could face. And from the implementation side, I think that we're currently facing a unique challenge, which is that we just, we are just deploying a big system. So some of our systems, or some of our hospitals are on Epic, some of our hospitals are on old systems. So when we develop models, and those two systems actually is not straightforward one-to-one mapping. So when we collect data, we found, oh, we have to do double work, basically, right? To get data. And also we want to implement them. And, some project has to be on hold because we will say, oh, let's read data, like let's collect it from Epic, wait, right? Rather than just using old data and then not applicable anymore. So that also says that things change. So our model or our data can go out of date. And then that's another challenge, that how we can keep learning our models and then maintain the models. If we have like 100 models, who are going to maintain them? Who are going to, keep learning and keep updating these models? This is also another challenge we're facing potentially. Yes.
Yeah, I couldn't agree with you more. And it'll be very interesting over the course of the next few years to see how this all goes as the bulk of institutions start implementing these things rather than just the the leaders at the ragged edge. And thinking about the future, I think we did a great job on nailing down that question. So I'd like to move on to one last question. I think we have about 10 minutes or not even left. And that question is, how will AI transform hospitals over the next 5 years? And I'd like to put a couple of stipulations on this one, make it a little more interesting. I think we need to emphasize hospitals, not just healthcare, because we're talking about hospitals in this panel. And I'd like everybody to try and answer the question in no more than 2 minutes, and then whatever time is left, we'll leave to open discussion. Okay, so start thinking about your answer. I'm going to start with Sanjay.
I'm on the clock. In the 2-minute drill, like clinical AI, I think we could spend another 50 minutes just talking about how to enable physicians to be able to care for folks better. I think engaging members, people who attend, who visit you at your hospital, and how you build both a virtual and physical relationship with them, and think of that as a continuum. Those will be heavily impacted by what we can infer with machine learning. But if I had to say, like, my big one is, hospitals are starting to look a lot like payors. Like they're taking risk, taking delegated risk. I think for some of those listening today, I'm still learning about direct contracting and what that means to large hospital systems, small hospital systems, everyone in between. And I wonder if there's a moment for hospitals to think about using artificial intelligence, machine learning to take that risk better, to understand how to serve a population affordably, how to maybe even price what that should look like, and do that very successfully. This sort of movement towards value-based care continues to march on, starting from those sort of pioneer ACOs to today. But I think it's sort of timely, but I think things like direct contracting are that next step in evolution for providers. And I think there are a lot of unknown questions about how you structure, how you think about serving a geography, how you think about serving a population. But I hope that artificial intelligence machine learning will reduce that overall administrative burden that comes with acting and operating a little bit like a payer when you move into that world.
Phenomenal answer. I loved it. All right, let's move on to Jeffrey.
Yeah, I think we've covered a bunch of my list for where AI will transform hospitals. I'll add a couple though. We touched on transforming care, obviously transforming work and back office functions, even a third area, public health, or thinking of that as a patient's community as well. How do you help a patient across their entire provider community? As kind of a third area, incorporating public health. There are lots of use cases there, but a fourth I'd mention are those digital transformation initiatives hospitals are starting to engage in, everything from apps and portals for patients and providers to, again, extending that care across broader communities, leveraging the patient record and all sorts of other data sources and insight engines. So that's going to be, a continuation of the telehealth and virtual care that we've seen, blossom in the past year, obviously. And then my fifth is that trust element. So there's just going to need to be more attention as there become more use of AI solutions in all of these areas, to make sure accuracy, fairness, explainability, bias, et cetera, are all accountable. The regulators over this 5-year time frame will get into it more, already discussing ramifications on compliance and risk management, but especially the clinicians, obviously, need to know these are solutions that augment what they're trying to do to drive quality care. So, that's what we're really focused on is that kind of clinical trust element. I think that'll be pretty transformative over this time frame.
Fantastic. All right. Last but not least, Sanji, what do you got?
Yeah. Okay. So I think I echo what Jeffrey just said that about trust. I think that the AI is gaining more and more trust. Actually, one concern is that people or physicians tend to overtrust AI, especially when they're young and they don't have lots of experience, and they can be biased by what AI tells them. Compared to previously, they perhaps would resort to let's say a seasoned or experienced medical doctors, right, for advice. And that potentially could be a challenge for AI as well as for the hospitals. I think that so then it will not, if they come across a bad sign, right, they didn't learn a big lesson, then perhaps, oh, I shouldn't trust AI. So I think the trust will be like spiral curve, up and down, up and down, up and down, and then to some balance that decide when I should trust, learn where to trust AI. And eventually, I think that AI would have his position, appropriate position, eventually to the hospitals and the patients. Yeah, thanks.
Yeah, Hamilton, I wonder if we flip it back to you, like as a clinician at a hospital system, like what are you going to need when you engage a patient in a virtual setting? Like they're not coming to your clinic, they're not coming to you physically. There's probably information you want about their previous engagements and settings. There's information about their current environment. And that's a lot of information. Like, how do you want to summarize it? Because, I think we always think about it. We almost start with the physical setting as a starting point. I wonder if we should be starting to think about the virtual engagement as the starting point. And then what is the information you need to know?
Well, that's a great question. In my opinion, what a clinician wants summarized for them in their initial interaction with a patient, be it virtual or in person, there are some basics. And I think that straightforward past medical history, procedures, et cetera, the old classic history, family history, social history, all of that. But what is important to different areas of medicine, such as an internist or a cardiologist or a pathologist who probably wouldn't be interacting with patients, but it's very different. In my little niche of medicine, pediatric cardiology, there are very specific things I need to know. All information is useful, and I went to med school way before all of this, a lot longer than I'd like to admit. But we were taught to gather as much information as possible, but it's just not practical in today's medicine. So I honestly think to create a product like that, you'd have to create a general framework, and then you'd have to put a lot of energy into tailoring it for each specific area and give the user the ability to tailor it. And I think that's where you'll get value, because clinicians love to tinker with things that are going to make their day go faster. And even if they only gain 30 seconds, you multiply that out after day. And if they've done it themselves, then they own that product and they are its biggest fan. I think once you saw that process with EHR, right? Once you figure out how to use those dot phrases well and that kind of thing, and you streamline it. So the products that come to hospitals for physicians and other clinicians to use, I think they need to have that user interface to be able to be modified. They don't have to be able to mess with how the model works necessarily, but be able to curtail it to their specific area. So if there are any last comments about that, I'd love to hear it, but I think we're just about to wind things up here.
Oh, it makes a ton of sense. That's a great perspective on how, your clinical interaction, how you'd expect it to work if we applied artificial intelligence and machine learning.
Well, great. I wish we had another hour to keep chatting. And it's been fantastic meeting all of you and having this conversation. Honored and pleased to have been a part of it. I will turn it back over to you, Patrika, and we'll conclude this session.
Awesome. Thank you so much. And a huge virtual round of applause for our panelists. And a special thank you to Hamilton for moderating. This has been an awesome conversation, and I know the audience enjoyed it. So thank you all for taking the time to share these insights with us. All right, for the audience, it's time for you to make your way to your next session. Along the way, make sure you stop and accept those connection requests and check out our amazing AI exhibits. Thanks so much, and we'll see you around.